Go.
Hello everyone, and welcome to the Independent Sage briefing. In the UK, vaccination against COVID has been a lifesaver and has helped us reduce the damage of the COVID pandemic. But is this the case everywhere? Currently, while more than 70% of the population in high-income countries is vaccinated with at least one dose, the number stands at around 28% for lower-income countries. So that's 3 in 4 people having received the vaccine, at least one dose of the vaccine in rich countries, and just 1 in 4 in poorer ones. And this shows the stark inequality in vaccine distribution and availability around the world, and paints a picture of added burden on nations that were already burdened and economically disadvantaged. This and a general outlook of the global status of the pandemic is what we're going to consider today. And for this, we have a very special guest as well. I'd like to give a really warm welcome to Dr. David Nabarro, who is co-lead the UN Global Crisis Response Group and Special Envoy of the WHO Director General for COVID-19. Thank you, David, for joining us today.
Thank you.
Before we get started with this discussion, I'm going to, as ever, invite Professor Christina Pagel to give us a presentation on the latest numbers. Over to you, Christina.
Thank you. Let me share my screen. Okay. So today I'm going to cover a brief overview of vaccinations, prevalence, variants, hospitals and deaths. I'm then going to just cover the latest long COVID data that came out yesterday, and then spend a little bit of time at the end just talking about the strain that the NHS is under as we go into winter, because I think it's something that we just need to be aware of and need to be pressuring our representatives to do something about. So just quickly on vaccinations, this is the status of the autumn booster. And you can see we've reached really high coverage in the older age groups, but unfortunately, just over half of 50 to 64-year-olds have received the autumn booster, and it is flattening off. And that's kind of a disappointing uptake in that age group. And just a reminder that people who aren't eligible for the autumn booster, only 7% and 28% of people have had a booster or vaccine dose in the last 6 months. So we still have a significant number of younger adults and obviously children who do not have a recent protection from the vaccine. On prevalence, the latest ONS infection survey came out today. And what it's showing is that while numbers in Northern Ireland and Wales are still going down, there's been a very small uptick in England and Scotland. And it looks as if this is the kind of floor in the Omicron era of somewhere between 1.5% and 2% prevalence. We haven't really been able to get below that for quite a long time now, and which is still actually quite a high level of infection in the community. Just looking at the most recent 4 weeks, you can see, it's not massive increases, but it is a definite increase in England and Scotland. Things are still going down in Wales and Northern Ireland. In England, where we have a bit more detail, the increases are mainly in teenagers and young adults. That's where we're seeing numbers going up. And regionally, it's pretty much everywhere except the northeast and northwest and the east of England. Just have a quick overview of variants. So this is the proportion of sequence cases over time for the pretty much since the autumn of 2020. You can see the Alpha and Delta waves. This is Omicron. We had BA5 actually for quite a long time, 4 or 5 months in the UK, but now it's the BQ1 and BQ1.1, mainly BQ1.1 subvariant that is now dominant in England. But the other thing that you can see is that basically since last spring, there's just been this Omicron seep, which is this grey area. So it hasn't reached this kind of dominance that Delta and BA1 had, that basically you've got a lot of other things happening. And in that Omicron seep at the moment, are 2 other Omicron subvariants, XBB and CH.1, that are now each 4% of sequences and are growing. and CH.1 is growing the fastest. So I don't know quite when we'll start seeing that one here, but just keep an eye on it. In terms of hospitalizations, this is the number of people in hospital for UK nations up to the 30th of November, except Northern Ireland, which only goes up to 24th. And this really is consistent with the ONS infection survey that we just saw, things going down in Northern Ireland and Wales, and flattening off in Scotland and England. And looking at admissions with COVID in England, you can see, this is just since April, you can see it has now started to go up again. So again, it does look really as if we're at the start of a new wave. We don't know how bad that wave is going to be. Hopefully, this pattern will continue and the peak will be lower than previous peaks, but nonetheless, it is not necessary. Well, it's not a welcome sign. About a third of people with COVID in hospital are there because of COVID, primarily because of COVID. So you're still seeing quite a lot of what are called incidental admissions, but that doesn't mean that they're harmless. If you're in hospital for other reasons, it's still bad to have COVID on top of it, and it also makes it harder to prevent infection within hospitals, and also makes it more risky for staff who might then get infected. And there's a lot more than just COVID this winter. So, every COVID admission adds an extra strain on the NHS, but there's a lot more going on. There's the massive record historical backlog of people needing care. But as well as that, we are now seeing rising flu admissions. So this is flu admissions in England up to last week. And you can see here, this is flu admissions. They're now starting to reach the level of the COVID hospital admission rate. And when it comes to intensive care, so the most severely ill people, this is flu. And you can see that flu admissions into ICU are now quite a lot higher than COVID ICU admissions. So flu is now starting to put a strain on hospitals as well. In terms of who it's impacting, you can see it's really flu, as ever, is impacting the very youngest here, the under 5s, and the very oldest, the over 85s, are most at risk of flu. And then the next biggest groups are the 75 to 84-year-olds and the 5 to 14-year-olds. So that's kind of how flu works. So if you're eligible for a flu vaccine, please do get it. I think it's quite well matched to the flu strain this year, so should be pretty effective. As well as flu, there's also another virus called RSV, which is another type of respiratory virus that causes kind of coldy, flu symptoms. And again, this is now increasing rapidly. This is hospital admissions with RSV in England. We're seeing a lot in the under 5s. And the next biggest group, again, is the over 85. So these are kind of the groups being hit a lot by respiratory viruses at the moment. And it's leading to headlines like this, where hundreds of children's hospital beds are closed amid this surge in England. And on deaths, I just wanted to highlight this chart, which is the ONS death certificate data, so people who have COVID on the causal pathway in their deaths. This is the peak from the kind of September, October wave. We're now coming down from that, and that's been seen in the deaths. If we are now entering another significant wave, you will see this go up, but probably not for several weeks yet. The long COVID data came out yesterday. I'm not going to say too much about it, except to say that it's staying high, still over 2 million people reporting ongoing symptoms at least 4 weeks. That's over 3% of the population. It's gone up a bit since October. I mean, not massively, but gone up a bit. And I think, to me, what this is really saying is that there will be people recovering from their long COVID all the time, and coming out of this population, but they're being replaced by new people developing ongoing symptoms. So long COVID is not a problem that's historical or gone away with loads of infections and loads of vaccines, right? It's still here, and it still matters, and it's still where we should try and avoid getting infected. And this kind of makes the point again of the era when people got infected who now are reporting long COVID, is that there's a significant bunch of people who got it in the first year of the pandemic, pre-vaccine, who are still suffering 2 years later. But there's also a really, really large proportion of people who developed new symptoms, ongoing symptoms this year, right? Just because we've had so many infections in the Omicron era. And just kind of the last point on long COVID is if we look at the professions that are most affected by long COVID, you can see, you know, well over 5% of people working in social care report ongoing symptoms, and not just ongoing symptoms, but ongoing symptoms that limit their activity at least a little or a lot. And the third highest is healthcare. Now, these are already professions where we have massive labour shortage. So you cannot afford to have your staff going off chronically sick in these professions. And just a reminder of a study that came out in July from the Institute for Fiscal Studies, just saying, you know, that long COVID is costing UK workers a significant amount of money in lost income. And again, we're just in the middle of a cost of living crisis. So just finally, some slides on NHS strain. So this is the percent of ambulance discharges that take longer than an hour, right? So when an ambulance arrives at hospital, the idea is that you should be able to hand over your patient to hospital care within 15 minutes. And that then frees up the ambulance to go and care for someone else. The longer it takes, the worse it is for that patient, but also the worse it is for the patients waiting for that ambulance crew. So this is the kind of, it's measured every winter between November and March. And this is what's happened over the last 5 years. So this is 2018-19 winter. It goes from kind of end of November to March. This is 2019-2020. The pandemic kind of started in March 2020. So this is pre-pandemic. There's always an annual dip over Christmas, but you can see that somewhere about, you know, 3 to 4% of handovers took over an hour. This is now 2020, 2021, which is kind of the first full winter of the pandemic. This spike here corresponds to the big alpha wave we had in January 2021. You can see that the ambulance service is kind of taking longer than it has before. But then England was in lockdown for these 3 months. And actually that led to it seems like much lower demand for ambulances during that time. Then we get to 2021, 2022. And you can see now that handovers are taking significantly longer. This is kind of the Delta burden in the late 2021. This is Christmas. And this is the Omicron BA1 wave this January. And you can see there was a big spike. It came down, but then BA2 started taking over until we had the big spike in March 2022. And you can see the ambulance handover times were just increasing that whole time. So that's kind of this last winter. And this is where we are now, right? We're just at the start of 2022, 2023 winter. We're starting higher than we've been in the last 5 years, right? Starting off much worse than historical values. And this is a consequence of a year of NHS emergency care crisis. We've been highlighting it in Independent Sage, NHS bosses have been highlighting it, journalists have been highlighting it, hospitals have been highlighting it. We haven't solved it, and it's getting worse and worse and worse, and it's creating more pressure. And so we're in a situation now where it's just failing. And you're getting headlines like this in the BBC from last week. You know, patients are dying as ambulances face crippling delays. And it's not just ambulances. This is occupancy, number of beds occupied by patients with long stays in hospital, more than 3 weeks. And you can see this is previous winters, and this is this winter. We're heading into it with incredibly full hospitals. We can't get patients out of hospital. I'm sure the clinicians on this call can talk about it more than I can. But we're in a situation where, you know, things are going to get bad, basically, unfortunately. And on top of that, we know that staff have been more sick this year. The data for 2022 only goes up to July at the moment, but you can see this pattern that there's been consistently more sickness in staff this year than in previous years. And again, that makes it much more difficult for the NHS to provide care. So just to summarise, ONS prevalence and hospital admissions data suggest that we are entering into another wave, but only just, right? We're right at the bottom of it. So where it's going to go and how high and how fast, we don't know yet. The current dominant variants are BQ.1, BQ.1.1, but there are a couple of new ones growing, in particular this one called CH.1. Long COVID numbers remain high and highest in key sectors such as health and social care. And NHS issues are compounded by 18 months of crisis, rising flu, rising RSV. The metrics are all bad. There is not a single NHS metric you can look at and see improvement in, right? Things are as bad as they have been for several years now. And it's only the start of winter. And so on that kind of cheery note, I will stop.
Thank you very much, Christina. That was really rather depressing. But thank you for the information. It's good to be informed. We're now going to move to our next section, and I'm going to invite Professor Anthony Costello and Dr. Zubaida Haque to introduce our guest properly and kick off the discussion.
Thanks, Helen. Just to let everyone know, David Nabarro has been an Assistant Secretary General to the United Nations. He's advised on food security, Ebola, other emergencies. He was coordinator of the Global Scaling Up Nutrition Movement. In 2017, he came second in the election for becoming Director General of WHO. Previously, he'd advised Gro Harlem Brundtland when she was Director General. He was also a Chief Health Advisor to Secretaries of State at the Department for International Development. And he has a lifelong interest in food insecurity and nutrition, for which he won the World Food Prize. And as Helen said earlier, in the past 3 years, he's been a special envoy on COVID-19 for the World Health Organization. And 38 years ago, I had the privilege of working under David when we had a lot of fun and I learned a lot when we both worked for Save the Children Fund in Nepal. So welcome, David, to Independent Sage.
Thank you.
And,
thank you very much.
And
Nice.
I'll kick off by just asking you a general question. You know, the very interesting stats, of course, from Christina. How do you see the current global status of the COVID-19 pandemic?
Thanks very much. Thank you, Tony. The pandemic's not finished. And I just, if I only manage to get one message across today, it is that it's not finished, and we don't know what the trajectory of the pandemic is going to be like in coming weeks and months. So we also cannot predict its ending either. And given that, I thought it useful if I actually present what's happening with the pandemic, not in terms of something that is reaching the end of its life, but something that could well be in the middle of its life. It's still a public health emergency as in the classification of WHO, which means it's the highest level of emergency that WHO can declare. And here is what is being seen in the WHO statistical analyses that try to detect what's happening around the world. Quite simply, about 8,000 people died with COVID as the diagnosis in the last week. This is in a context of 2.7 million people reported to have COVID in the last week. I spoke yesterday in preparing for this with the technical leads in WHO's emergencies department, and they said that their rule of thumb right now is there are probably 5 times as many people with COVID actually experiencing the disease as are collected in the statistics. If that's the case, then we're running at somewhere around 12 million cases a week. I mean, that's a lot. And I just thought I'd tell you where we are seeing increasing trends. The numbers are going up in the Americas. The numbers are going up in the region that we call Western Pacific region, particularly in Japan and South Korea. So don't again assume that there's a universal decline in the reported numbers of cases. We have this unevenness, and we do actually think that there is the beginnings of a global new wave coming up at this time. I thought it might interest you, Tony, if I spend a minute or two concentrating on China. The situation in China is really quite challenging for the Chinese authorities. I mean, altogether, there's been about 1.5 million people with infections reported in China. in a population of 1.4 billion. So you can quickly work out that's sort of around 1 per 1,000, something like that, of people who've been reported of having the disease. And the number of people in this 1.4 billion population who are reported to have died since the pandemic started is about 5,229. That's 5,229 in 1.4 billion. Just compare with the UK. The current estimation is that about 90% of British people have experienced COVID at least once. And the death rate in the UK is estimated at around 2.4 K, that's 2,400 per million. So you can see the difference between the UK and China is extraordinary. 90% of people probably have been affected, death rate of 2,400 per million, whereas the total number of COVID deaths in China is 5,229. Why am I saying this? I want to convey to everybody that the situation in terms of numbers of people in the population who've been exposed, who've got sick and who've died in China is really very, very much smaller than the similar caseload in the UK. Now, that means that the challenge facing the authorities in China is particularly serious right now. And it's compounded by another statistic, which is the percentage of the population in China who've been boosted, particularly the percentage over 80 years of age. I'm sure you all have some rough idea what it is, but just to confirm, it's about 40%. So compared with the figures that Christina just showed us for what's happening in the UK, the actual vaccination coverage of older people in China is remarkably low. So taken together, a low level of actual infection and a really quite low level of immunization boostering older people means that for the Chinese authorities, there is a real risk that if the virus starts to move in a more dramatic way across the population, that there could be a very high level of severe illness and death quite quickly. And that's what I'm trying to convey to everybody everywhere, that there's no simple way to say that this pandemic is moving towards its end point. It would be premature to do that. There could well be a very high level of infection and even of mortality in China, and that's such a large country in terms of global population, that could well contribute to the emergence of new families of variants beyond Omicron that might also have major consequences were they to move to other parts of the world. It's just not reasonable to assume that with this really quite unstable situation in China, that the West can start behaving as though the pandemic is behind us. Yesterday, I actually heard a member of parliament in a very senior position refer to the pandemic in the past tense in the UK. And I said as quickly as I could afterwards, please don't use the past tense. Please remember that this is a pandemic, so what happens outside the UK is highly relevant to prospects in the UK. The present situation, particularly in China, is pretty unstable and could well lead to new variants emerging, could certainly lead to quite high levels of suffering and death if it's not handled with extraordinary care. And at the same time, we are seeing cases rising. We just don't know how much to believe the numbers in parts of North America and Latin America. And so that brings us overall to a situation of pandemic ongoing, really very serious situation in one large country that's about a fifth of the world's population. And as we've heard from Christina, plenty of variants moving around and ready to cause more trouble, with anxieties still in too many parts of the world as to whether we can ensure that those most at risk continue to be properly covered with boosters. Back to you.
David, thank you. That's a great snapshot. And I think most of us, I think all of us on Indie Sage would agree very much with your your expression of concern that this is certainly not over. Can I hand over to Zubaida just for a couple of questions?
Yes, thank you. Thank you, David. That was absolutely fascinating. And actually, some of what you said about the outcomes, the sort of really regrettable and avoidable outcomes in the UK lead me nicely onto one of the questions that I want to ask you, which is really around the lessons in the UK response. Because on the one hand, in terms of vaccine rollout, or the speed of the vaccine rollout and uptake among some of the population, some of the key members of the population, but of course not all. On the one hand, the speed of the vaccine rollout was actually something that was quite positive and well regarded. But on the other hand, in terms of, especially at the beginning, the implementation of the restrictions and especially, lockdown, and subsequently in terms of other restrictions, we were consistently late. We didn't really put a protective ring around social care until it was quite late, and it was wholly inadequate in terms of looking after elderly people in social care homes. So I wonder, do you think you could tell us a little bit more about what you think are some of the lessons that you think we can learn from the UK response?
Thanks very much indeed. Of course, it's really extremely difficult to compare outcomes across nations in a way that is meaningful, because first of all, the way in which the virus behaves is complex. And when you link that to the multiple elements of response, you get a massive increase in complexity. And so I'm really very careful indeed about making comparisons. And I want to say that in addition, because we're not at the end of this pandemic, I also feel that we haven't really got endpoints with which those comparisons can easily be made. So I can understand the question you're asking, and I can also understand a bit, I think, the basis of that question. But I'm going to slightly sidestep, and I'm going to comment on lessons that I am learning from the collective of responses that I see around the world. Within that, I want to try to situate the UK, but I don't want to go much further in making anything that might be seen as an assessment. I hope that is a reasonable starting point, and I'll accept that you may want to push me on that. Now, in terms of approach, most countries started with a focus on containing and seeking to interrupt transmission of the virus. There were no vaccines at the beginning, and so public health and social measures were used as the basis. And there was quite a lot of debate about the relative roles, especially of the use of face protection at the beginning, in the early months of 2020 and so on. As 2020 advanced, so vaccines were being produced, and then we moved into 2021, and many countries, but especially those that were able to access quite significant amounts of vaccine, either because of a domestic production program or because of intensive imports, or both, started to shift from public health and social measures being the dominant approach to the use of vaccines. really to try to save the lives and protect the livelihoods of those who were most at risk of severe illness and death. So that meant that the vaccination process was skewed, especially at the beginning, towards trying to make sure that the most at risk were the first to be protected. And as you've already implied in the earlier remarks, this has been a remarkably successful strategy when it comes to reducing extreme morbidity and mortality. Now, the challenge has always been to try to make sure domestically that you've got enough vaccines available and in store so that you can maintain the efforts to get a high population coverage, at the same time reassuring those who are driving the strategy that you've got enough vaccine, especially at the beginning, when at the same time the world is having to try to vaccinate all the people who are at risk with very limited amounts of vaccine. We're talking about early 2021. And in fact, the first lesson that I want to put before you is just a simple one, that there was not a global approach to ensure fair access to scarce and vital resources when they started to come on stream, particularly the vaccines in 2021. But then when we explore it, we find that there were similar difficulties with getting equitable access to diagnostic tests as well. Now, we've been through this before. We went through this as a public health community with trying to enable people with HIV to have access to treatment when, at the beginning at least, treatment was really very expensive. But it was possible by creating a series of processes to discount anti-HIV medicines for poorer populations, plus setting up a large international funding mechanism to actually enable poorer people in poor countries from quite an early stage in the HIV response to get access to medicines. It was considered to be a right, and it was considered to be part of global responsibility. But gosh, on COVID in early 2021, it seemed as though all those principles had vanished, and there was no universal COVID vaccination program that was doing more than trying to find a way to get the stuff that the rich nations didn't want to poor nations through a lovely thing called COVAX. But the trouble with COVAX was that if the rich nations didn't stick by the rules, then poorer nations just had very little opportunity to access the medicines they need. Lesson one, equity matters when you're dealing with infectious diseases. It matters so much. There's no difference in the capacity of rich people and poor people to get sick. But there is a huge difference in their illness experience if they have differing access to vital protective measures like vaccine. My second lesson, I only have two. As well as needing a global approach to try to ensure some degree of equity, what's also vital is to empower local responses that can adapt the various measures that are being used to the local epidemiological and operational situation. And over time, we've seen more and more that to be able to detect a spike in a local community quickly and then to act with a mix of public health and safety measures, targeted vaccination, and, if necessary, localized movement restrictions is key to preventing spikes to turning into explosive outbreaks. But it needs to be local. Although you are operating within an overall national or even global strategy, because this is primarily a droplet-borne infection, it may be airborne in certain circumstances, but we still in WHO context, it's primarily droplet-borne, the spikes of infection tend to be hyper-local, at least at the beginning. And that means that ensuring that responses are also locally planned, integrated, organized, evaluated, and I believe also supervised is a key element of successful responding. So those are my two main lessons. I would like to wrap an awful lot of other lessons around inside it. But the first one is, without attention to equity from the start, when dealing with these kinds of public health challenges, we are creating huge handicaps for ourselves, but more importantly for the patients and people that we serve. And secondly, within the context of an overarching strategic direction, it is essential that actual implementation of responses is as locally organized and facilitated as possible.
Yes.
David, thank you. Can I just step in, because we're running short of time, but I just want to pick up on, you've made some incredibly important points about equity and devolution and the rest. One issue that, of course, is hitting us really big this year, and I know it's very close to your heart, is we've known for years that infection risk, such as for COVID-19, is very linked to nutritional status. And, you know, you've had a lifelong interest in this. How do you see the situation? I mean, at the moment, governments have to respond to some quite dramatic evidence about rising food insecurity and hunger among millions of families, even in the UK and across Europe, as well as in all the, you know, the high-risk populations in the Horn of Africa and Southern Asia and the like. So how should governments be responding to this? And does this worry you that the impact of the pandemic as it continues on is actually going to surge a bit more?
Thank you. The cost of living crisis that's been experienced around the world is endangering the well-being of, we believe, in the United Nations, at least 1.5 billion people in 94 countries. And there are tens of millions of households in these low and middle income countries who are sliding into deeper poverty all the time. It's the most rapid slide into poverty since the Second World War, and it's affecting the nutrition, health, education, and overall well-being of, as I said, tens of billions of household members. Now, I want to ask you not to view this just as a food crisis or as a hunger crisis. It's food, energy, finance, and most importantly, a poverty crisis. So I think that the question then is, are poorer households more likely to experience increased hardship as a result of being infected with this virus that in many parts of the world now is moving around without too much restraint? And the answer is yes. They're more likely to be exposed. They're less likely to be able to isolate themselves. They're less likely to be able to access treatment. They are less likely, indeed, to be able to shield others from infection. The dice are deeply stacked against you when it comes to an infectious disease like COVID-19, if you are poor or if you are from a poor community. In addition, Tony, I think you're right that your food basket, if you're poor, because of the cost of living crisis, is less nutritious. And it's probably also more hyper-processed. And in the view of many, that is likely to lead to a reduction in the capacity for immune responses. The links are not 100% clear, but overall, we know that poor people's experiences when it comes to COVID are much nastier than wealthier people's experiences. And we know that this cost of living crisis is leading to a vast increase in the extent of poverty in our world, which in my judgment is going to make preventing yourself from getting COVID and then acting to reduce the danger of the infection when you have been infected, just going to make it more difficult. So yes, I think you're right. The cost of living crisis is likely to make things much worse, especially for poorer people.
The final question that I think Zubaida and I wanted to know about, but I'm not sure, we're almost at time, and it's such a big question. It's about how we construct a global system for pandemic preparedness. Maybe we could get you back another time to answer that in much greater detail, because this is...
But Tony, just quickly.
Yeah.
It's a really difficult time to be encouraging worldwide connected responses to any existential crisis, whether it's due to COVID-19 or accelerating climate change or increasing frequency of violence, conflict, or widespread inflation with reduced fiscal space in countries to be able to respond to it. And so I just want to stress to you that the most urgent thing in international affairs right now is to find ways to re-establish the levels of trust and interconnectivity that are necessary for true global responses to big challenges. I'm speaking here, having listened to the Secretary General of the United Nations, really experiencing a very big anxiety, because in the end, the people who miss out when you don't have a true multilateral response are poor people in poor countries. They can't get the cash they need to be able to mount their responses. They can't get the resources they need to be able to participate in global programs. And all in all, they are not able to do what they need to do for their people simply because they're at the end of the queue. And, you know, in 2015, even, we were able to talk quite openly in international negotiations about leaving no one behind and putting the hardest to reach first. These are not at the center of international dialogue right now. And I would like to ask that you all in this age and in your other connections and networks that you have, to stress that we are going to have to invest in re-establishing the multilateral system, because without that, as a world, we are so much weaker when trying to face some really very difficult threats.
Thank you. That's a great note to end on, because, you know, multilateralism has been given a punishment for the last 20 years. And I think absolutely what you're saying is crucial if we're going to get out, not just of the pandemic, but also deal with other crises, particularly climate change. David, thanks ever so much. I know you're busy. It's been great having you on. We may try and get you back next year. But thanks once again for joining us.
Thanks for all you do, every one of you. And I would disappear and look forward, if ever I can be any help, never far away. Bye-bye. Bye.
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 Back to you, Helen.
Thank you very much, David. That was absolutely fascinating and really very inspiring. I'd like to move on now and take some questions from the public. And we've got a few who are joining us here. So first question comes from Charles Spencer. Charles, are you there? Please do turn on your camera and your microphone. Yes, go ahead.
Thanks very much. My question seems a bit micro compared to the sobering issues that Dr. Nabarro raised, to say nothing of Professor Pagel's depressing UK update. But it's really a follow-up to a question in your last briefing about the sensitivity of tests, where basically your conclusion was don't trust a negative test if you have symptoms. I think that came primarily from you, Helen. My question is about the reverse situation. Is asymptomatic infection still a thing with current variants, and in what proportion of infections? Because except for the ONS survey, we seem to hear only anecdotally about cases where people test because they have symptoms. And I suspect that that's biasing both statistics and especially public perceptions. So I'm continuing to test preemptively, even if it costs, which I think is bad policy. And I hope others I meet will do likewise and not depend on having symptoms. So what's the current story on asymptomatic infection?
Right. Which of our panel feel able to answer that one? Do we know? Steve, please.
As far as I understand it, it's similar, and as well, because Omicron is that much more infectious, it takes less of the virus to infect you. So that's one reason why the tests aren't so good at picking things up in the early stages of infection, but are better once that infection has become established and is sort of on its way out. So there was a very good study not long ago that showed that quite nicely, correlating it with the level of infectious particles that you can harvest from people's noses and what have you. So there is still asymptomatic infection. I think that much is clear. It's used to be estimated around about a third of infections, where I haven't seen any data to say that that's not the case for Omicron. I haven't seen any confirmatory data that it is, but I do think it's about the same as Delta. I think that as well, in questions of when we test, it's very clear that asymptomatic screening is very important if you're wanting to do this when prevalence is high. If prevalence is low, then it's not worthwhile doing it because it's very hard to pick that up. But when prevalence is high, as we have now and we're about to see through Christmas, then yes, it's worthwhile doing, but it's better doing it as a population rather than as individuals. So I'll let someone else answer the rest of that.
Christina.
Yeah, so just to say, asymptomatic infection is definitely still a thing. But I think, as you pointed out, most people only test if they have symptoms, and actually most people, if they have symptoms, don't test, even then. I think it is a big issue, partly because the actions you can take on a positive test have shrunk for many people. Often people are now being pressured to go into work, even if positive, and particularly if positive and asymptomatic. And so if you don't have an avenue to be able to say, to isolate yourself, how does it benefit you to do preemptive testing? And that, I think, is just a big, well, it's a worry for individuals, but I also think it's a failure on a public health system. And that's why we need better sick pay and to support people if they stay home, if they test positive. Personally, I test if I know I'm going to be seeing vulnerable people like my parents. But, it's not ideal.
Okay, thank you very much. And thank you, Charles. Hope that answered your question. And our next guest is Julia Cameron. Julia, are you there? Would you like to turn your camera on? Hello, Julia.
Hello, can you see me?
We can.
Okay, thank you for your work. I really appreciate it. My question is, how can we improve COVID awareness and safety in hospitals? This week, I went for a hospital consultation, which I had long delayed because of the pandemic and being clinically vulnerable, but I couldn't continue to put off. Although the sign at the hospital entrance asks people to wear masks, many were not doing so, including some of the staff. What can we do to improve the situation?
Any takers for this really very important question that affects lots of our listeners? Susan.
Yeah, thanks. Incredibly important question. And when you say we, I think you're meaning members of the public, patients, relatives and friends of patients, the whole network of people. And I think there's going to have to be, or what we should be doing is many things simultaneously, just thinking about all the avenues of influence we have. I'd say the first is not to be worried about saying to staff or other people in the hospital, I'd appreciate it if you were able to put your mask on. Is there a reason why you're not wearing a mask? And just ask people. In my experience, it leads to positive responses. And sometimes people just don't think about it, they've forgotten, there's all sorts of reasons why they're not. So that helps to spread awareness. What other routes have we got? Writing to the local papers about it. Certainly in Camden, where I live, there are sometimes letters deploring that there aren't 100% take up of wearing masks in hospital and other social and healthcare centres. That's another avenue. Thinking about potentially the PALS, the patient liaison service, seeing if there's a route through there, talking to friends and neighbours and colleagues about the issue. You know, really, I think everybody is in a different situation in terms of where they can have persuasive influence. But, you know, if all of us do that, it might seem quite small things, but, you know, hundreds of thousands of small things add up to quite big things. So that's my first response.
Thank you very much. Anthony, you were going to say something.
Yeah, Julia, it's a great question. And you may remember the MRSA issues of about 15 years ago and Clostridium difficile spreading in hospitals, these antibiotic resistant strains. And at the time, they decided to have a big campaign on hand washing and, you know, revitalizing the whole infection control processes in hospitals. And I remember it because I wasn't particularly good at obeying all these rules. And you gave a very powerful nurse, infection control officer, the power over everybody to go around and make sure everyone was doing this with alcohol things. And it really did work. You know, public health works. And over the next year or two, the number of those cases fell down dramatically. The problem we have right now is what David Nabarro was saying. The message coming from senior people in government and sadly some advisors is the problem's over, the pandemic's over, it's all right for people to become infected. And in a hospital, that's a catastrophic way of approaching the problem. I completely agree with you. And I think we need to re-energize our infection control officers who are caught in this bind. You know, they would like to, I think, or many of them would like to see a bigger clampdown on this. But you raise a very important point.
Thank you very much. I don't think we've got a clear answer about how to do this apart from to keep raising that issue. Thank you, Julia, for your question. Our next question from Jay Wheatley is, COVID has highlighted the pre-existing inequalities in health, etc. in this country. What lessons can be learnt from this experience? Now, I think we're going to have a whole session on this whole topic quite soon. I don't know if anyone wants to preempt the next session and just tell us a little bit about their thoughts on this issue. Zubaida, you're my first pick.
Thank you. Yes. Well, first of all, quick plug. Professor Sheena Cruikshank and I will be co-hosting next week a session on inequalities. We'll be focusing on, in particular, deprivation and inequalities, as well as what we could do more for the future, really, to protect and recognize that this pandemic has been a pandemic of inequalities. There's so much we can do in terms of, or we should have done, in terms of protecting vulnerable groups, not just those with who are immunocompromised, but also those groups who are most at risk. David spoke about them briefly. You know, people in deprived areas, people who are poorer, who simply, because of their circumstances, because of where they lived, because of their high exposure, because of the types of jobs they did, because of the fact that they couldn't afford to self-isolate, had to go work to put food on the table, much more at risk. We didn't take enough measures to support them. And by taking away tests, by making tests something that we buy and so on, we're protecting them less. We'll be talking about this much more next week. There's a lot to go into, but it's a very good question.
And Sheena?
Yeah, I can just chip in with something very simple that could be done relatively easily. And that comes in light of a report that's just been published today, I think, which was surveying teachers in England and asking them what they've been noticing in state schools. And there's some really appalling facts, such as 38% of teachers were saying that their children were coming in hungry. And 17% were reporting an uptick in requests to access the food bank. So I think one thing that we can help, because we know that malnourishment, malnutrition, lack of food has a really negative impact on immune function, which is very vulnerable to infection. As Christina's shown us, we've got a triple-demic, RSV, flu, and COVID. So why don't we look at access to free school meals? That's something really easy that could be done.
Great point, Gina.
Thank you very much. And one more question, I think, which it's slightly long, but I shall read it all. It's from somebody called Joe Bowyer. My question comes from a place of ignorance, so excuse that. That's fine. Lots of us have got a lot of that. But why is it that there is a vaccine against some viruses like smallpox, which give, one assumes, lifetime protection against catching it, whereas other viruses like influenza and coronavirus, like COVID-19, mutate and vaccine needs constant rejigging? Why can't vaccines for COVID be developed that stop transmission? Smallpox may be a bad example. This is no longer around. What about, was that due to a vaccine? What about measles? Why hasn't this virus evolved? Are there no different variants of measles? So, Steve.
Okay, it's difficult. There viruses have different properties, which means that they're not as good at giving immune responses sometimes. But the major thing that you're getting at there as well is, and you mentioned the evolution of the virus as well as our immune response, which is primed by the vaccine. So it's a two-sided thing. It's two sides of the same coin. If you have a virus that doesn't change, then you can immunize once, and we're still using the same measles vaccine that was developed in the 1960s. Okay, then that is going to give you a good level of protection, and if you get the right sort of response, then that will also prevent transmission as well as severe disease. And the reason for that is that measles, because of the nature of the spikes on that particular virus particle, it can't change. It can't tolerate the sorts of changes that we see in SARS coronavirus 2. So SARS coronavirus 2 has this very variable top part of the spike protein, which seems to be able to just change, all the time. But there are less variable parts of the virus which people are starting to look at. So, for example, the stem region of the spike protein is less variable. There are other components of the virus as well that are less variable. So that's really the idea of going for a universal vaccine that the virus cannot escape from, or at least cannot escape from as easily. So until we start doing that, really, we're going to be stuck in a bit of a race. And at the moment, I'm afraid we're not winning that race.
Okay, I think that's probably answered that question. And as we're just about out of time, I'm going to say one more thing, which is we've had quite a few questions about the makeup of the vaccine and various scares about what might or might not be included in the vaccine. And I think it's, actually it's useful to be well informed about the vaccines. And for people who do want to know about this, we can direct you to the lovely new paper that is up on the IndieSage website. It's the mRNA vaccine resource, and you can find it on our website. And there's also some really useful stuff on the website of the British Society for Immunology, which is a really trusted source for information about vaccines. And with that, I think I'm going to say goodbye to everybody, and thank you very, very much to our guests who came on, to the IndieSage panel, and particularly to David Nabarro, who was such an excellent guest. See you all next week.
Thank you.
See you guys.
Bye.
Bye.